Good evening, and good evening all, and welcome to our weekly webinar. And today we have with us our Vice President of Section 16, Dr. William Cheung. Okay, Dr. William, today he's going to talk to us about COVID-19 and the dental practice. But a bit about background of Dr. William. Dr. William graduated from University of Pennsylvania School of Dental Medicine with DMD in 1981. He holds several appointments from the University of Wisconsin, especially adjunct associate professor from his alumni, University of Pennsylvania. He's also the associate professor at the University of Hong Kong and also honorary professor at West China School of Stomatology. Dr. William is a fellow from various academies in our fraternity, Academy of General Dentistry, Academy of Dental, FADI, of course, he's ICD, our fellow, American College of Dentists, International Academy of Dental Aesthetics, and also the fellow of Fauchard Academy. Professional organization, Dr. William also holds various chair at FDI in the Education Committee, and also he is the Emeritus Trustee. I think this is the biggest contribution to the dental profession in Pennsylvania. Emeritus Trustee at the University of Pennsylvania. Besides being a chair of Board of Governors, School of Dental Medicine of the same school in University of Pennsylvania. Okay, he has speak to various platforms. As I said, he's currently our Vice President of Section 15. And since he got a long list to got to mention, but I think he did no more introduction since we are already run out of time. So now I would invite Dr. William Cheung. Dr. William Stocky. So I hand over the floor to you for you to share with our audience tonight. Thank you.
Thank you very much for your kind introduction, and I'm sorry that we started a little bit late because of some technical problems that I was dealing with, but I'm glad that we got it worked. And so it's really an honor and pleasure for me to be presenting the challenge that we face today. You know, how do we manage this pandemic outbreak of COVID-19 in a dental practice? And it's a very important topic, and I know that others have shared similar topics before in this weekly webinar. So I hope that I can share something different and something useful for you. I also want to especially mention Professor Ibrahim and his contribution to these weekly webinars. And I think it's a fantastic platform for ICD fellows to share our knowledge with one another and learn from one another. And so I just want to pay a special tribute to Professor Ibrahim and the work that, a lot of work that he has put into these weekly webinars. As you know, I'm from Hong Kong, and Hong Kong is well known as a tourist destination around the world. And in addition to Ocean Park and Disneyland, we also have a lot of shops and also famous with international cuisine. Basically, any kind of food that you want, you can find in Hong Kong. And last but not the least, the beautiful Victoria Harbor is shown on the lower left-hand corner. That's the night view looking at the harbor from the peak. And so when it's safe to travel, all of you are welcome and visit Hong Kong, and be sure to look me up. This is going to be the outline that I'm going to be using, and I know that all of us are interested in the practice management aspect of how to deal with the challenge of COVID-19. But it's also important to have some background information about this pandemic outbreak, and specifically the virus that's causing this pandemic outbreak, so that we have a good understanding of its nature before we can come up with strategies how to deal with this outbreak. And so what I'm planning to do is to spend about 45 minutes talking about making this presentation to you, and then we'll leave about 10 to 15 minutes for question and answer at the end. And so we'll try to wrap it up within an hour. We heard about an outbreak of pneumonia in Wuhan, China in late December 2019. And this infection spread readily, to other provinces in China and over 200 countries worldwide today. And as of this morning, there were over 20 million confirmed cases worldwide, with approximately 750,000 deaths. So the mortality rate as of today is approximately 3.65%. And as you can see on the bottom chart, US leads the chart, followed by Brazil and India and Russia and so on and so forth. And the World Health Organization declared this a public health emergency on January 30th, and 12 days later, WHO named the viral disease COVID-19, which stands for Coronavirus Infectious Disease 2019. And the scientific name of the virus is SARS, which stands for Severe Acute Respiratory Syndrome, which is very similar to the SARS virus that we experienced in 2003. So the name of the virus for this one is called SARS coronavirus 2. And these are the typical symptoms, just like flu symptoms: fever, cough, and loss of smell, interestingly, comprises up to 60% of the infected individuals, and muscle weakness as well as fatigue with abnormal chest x-ray. And some of the less common symptoms include sputum production, headache, coughing up blood, diarrhea, which we're going to address a little bit later on, and then skin rash constitutes about 8% of the infected individual, and the loss of taste. Most of the infected individuals can recover on their own, about 80% of them, but obviously some have to be treated in a hospital. But a small percentage develop severe respiratory symptoms requiring ventilators. They are typically the older individual, especially those with compromised medical health, such as cardiovascular disease, diabetes, and so on and so forth. So according to the Chinese CDC, Center for Disease Control and Prevention, this is the diagram that shows about 80% mild cases, 13.8 or 14% severe cases, and approximately 5% critical cases. So among those who have compromised medical health conditions such as cardiovascular disease, about 1 in 10 of those individuals eventually die from the disease. And then followed by diabetes, about 7.3%, chronic respiratory disease, 6.3%, and then high blood pressure and cancer. So those with no underlying conditions, in other words, medically healthy individuals, their mortality rate is very low, it's less than 1%. So if we take a look at COVID-19 compared with some of the recent outbreak of viral diseases that we've been experiencing in the past recent years, to date, COVID-19 is about 3.65% mortality rate, compared to roughly 10% with SARS in 2003, 35% with MERS, and approximately 40% with Ebola. So as you can see, mortality rate is not really a major problem. It's fairly low. However, there are other characteristics associated with this viral disease that are very difficult to manage, and that cause a lot of anxiety among the health officials around the world. So a little bit of virology. It's this positive sense single-stranded RNA virus, and it's very similar to SARS and MERS, but this one is a beta coronavirus with a lot of spikes, protein spikes. the genome sequencing is very similar to coronavirus found in pangolins. The researchers found that there are 99% similarity. And so there was some speculations that because Chinese people, some Chinese people like to eat wild animals like the pangolins. And and you can find them in fish markets all over China. And so the speculation was that, one or two individuals, had eaten pangolins in the fish market and got infected and then start spreading the disease. But that was only a speculation and it's not confirmed as of today. The spike protein in the membrane envelope binds to the receptor site of the host and facilitate entry of the virus into the target cells. And in human, the angiotensin converting enzyme 2 or ACE2 is the host receptor, just like SARS coronavirus. And ACE2 cells are found to be present not only in the respiratory tract, but also in the intestinal tract. Thus, diarrhea is one of the symptoms we find to be quite common among those who are infected. And you can see from this diagram, the coronavirus with the spike protein, how they enter the host cell through the ACE2 receptor, and it fits perfectly well to the receptor site. So transmission routes, we know that it can be transmitted directly by inhaling the respiratory droplets via an individual's cough and sneeze. And if you look at this particular publication, the sneezes can go as far as 7 to 8 meters. That's pretty far. But typically, we're estimating approximately 1.5 to 2 meters. So if somebody is standing next to you sneezes or sneezes at you within a very close distance and you inhale the droplets from the sneeze, and if the droplets are carrying the virus, then you can get infected easily. And the other way to possibly get infected is by touching the infected surfaces and then touching your mouth or eyes or nose. And so these are the indirect transmission routes. As dentists, we are definitely in a high-risk category because we deal with sort of saliva and aerosol in a lot of the procedures that we do. So this chart shows you that dentists are indeed fall into the high-risk category. Fecal transmission is another possible route. The virus are indeed detected in stool samples of a lot of the infected individuals. And again, it's mainly because these receptor cells are also abundantly present in the intestinal tract of a human being. The other possibility would be something a little bit scary to us, that's asymptomatic transmission. And this has been found to be true a day or two before symptoms begin after an individual is infected. In other words, the typical incubation is about 5 to 7 days. So on day 3 and day 4, before the symptoms arrive, that individual, the infected individual, can spread the disease without even knowing. And so this was reported in the LA Times in March. A church choir decided to go ahead and have a choir practice with about 60 members of the choir gathering together in a small room. And then after 2.5 hours of practice, they were dismissed. And then 3 weeks later, 45 out of 60 singers were diagnosed with COVID-19 and fall ill and began to develop symptoms. At least 3 of them were hospitalized, and then eventually two died. And so the scary thing about this report, when I read it, is that it took 3 weeks for these individuals to develop symptoms. So as I mentioned earlier, the typical incubation is 5 to 7 days, but we have seen reports that up to 14 days or even longer. And in this case, maybe even longer than 14 days. So the virus stays. The other scary thing about this virus is that they can stay active for up to hours and even days on different surfaces. And so this was found in the CDC website or the FDA website. And as you can see, this coronavirus can survive on cardboard, aluminum, and copper anywhere from several hours to up to a day. And then on stainless steel, plastics, wood, and paper for 2 to 3 days, up to 5 days. And then on metal, glass, and ceramics for 5 days or even longer. And so that's something that we have to deal with very carefully. The other characteristic about this virus is that it's highly infectious. And there was a report or incidents in Hong Kong that a family of 11 were having a hot pot dinner together. And then about a week later, all 11 got infected by the virus. And then there were other reports about church gatherings around the world in South Korea and other places around the world. And as you know, church gatherings with a lot of people in a small room and sometimes can be a problem. Infected individual can spread the disease from one person to another very easily. So it's highly infectious. And it gets into the lungs quickly, and therefore a lot of infected individuals develop symptoms of pneumonia. Mortality, we mentioned, the elderly constitutes about 22%, others anywhere from less than 1% to above 10%. And this is to show you the high mortality rate for people who are 70 or above, and especially those with compromised medical health. To this date, there were hypotheses that there may be 3 possible strains, and as we all know, these viruses can undergo mutation pretty rapidly, and therefore there could be even more different strains with different virulence. But that's to be confirmed. Long recovery. Once an individual go into the hospital, especially if they have to be supported by ventilators, it takes at least 4 to 6 weeks if they can be treated to be successful in their treatment. And there's really no specific treatment modalities, and sometimes physicians will use a combination of different types of drugs to treat the disease, but it's pretty much depend on the individual and their symptoms. And then last but not the least, there's no vaccine available yet. And we all know that a lot of different countries are racing to get the first vaccine out. And today in the news, I heard that Russia has a vaccine that's been approved. Now, how reliable is this vaccine? How safe is it? How widely can it be available? We don't know. And even if there are multiple vaccines that may be available in months to come, we still have to wait and see, how safe they are and how readily available they are. So there are basically 2 different types of outbreak. The first one is what I call a traceable outbreak. In other words, the infected individual, we know how he or she gets infected, so there's a known source of infection. In this case, it's important to do testing, to do contact tracing, because if we trace all the close contacts of an infected individual, then we can go ahead and quarantine these individuals to make sure that whether they are infected or not through testing. If they are confirmed to be infected, then we have to isolate them so that they don't spread the disease to other individuals. So these are relatively easy to manage if we know the source of infection. So Hong Kong has learned a very painful lesson from SARS in 2003. So if you look at this simple chart, we had about 1,755 confirmed cases of SARS in 2003 with 300 deaths, whereas the global figures was only 8,437 with 813 deaths. And so we had the highest percentage of mortality rate with SARS. And that's the reason why the government with this disease started to treat it very seriously and try to do testing and contact tracing as much as possible. But currently, we're still undergoing a community outbreak that we identify some infected individuals without knowing what the source of infection is. And that becomes a challenge. So with COVID-19, as of this morning, Hong Kong has only 4,182 cases. And I say only because it's all relative, because when you look at the number of infected cases or confirmed cases in the United States, it's well over 5 million, with over 3 million in Brazil and over 2 million in India. So 4,182 seems like a small number. And we have 58 deaths so far as of this morning. So the percentage, again, is relatively low or low compared to average. And I mentioned to you the average mortality rate globally is 3.65%. And if you look at this number, it's slightly over 1%. So the worldwide total number of confirmed cases is over 20 million as of this morning, and roughly 745,000 deaths. So the other type of outbreak is what we call community outbreak, meaning unknown source, difficult to trace. We don't know how they get infected, and we don't know where they have been, and we don't know who they have been in contact with. And that becomes a public health hassle. It's really a headache to deal with community outbreak. And I think that is probably the main reason why US, Brazil, and India are experiencing such a high number of confirmed cases, because these are all community outbreak without a known source. So there are basically two different types of tests that we can do. The first one is called the antigen test. It's a reverse transcription polymerase chain reaction, RT-PCR test. It detects the genetic sequence of the virus RNA. And so basically what you do is you take a nasal swab or deep throat saliva in the morning before you brush. And then a few hours later, you submit the sample to the lab, and a few hours later, you can get the result. And it's fairly accurate. It's been estimated that accuracy is over 90%. And there are other rapid tests that you can get the result even faster than that, but their accuracy average anywhere from 40 to 75%. And I'm not sure, and they're pretty expensive machines, and I'm not sure if I want to invest a lot of money into a test that only gives you 40 to 75% accuracy. So I think this RT-PCR is really the industry standard at the moment in terms of an antigen test. The other one is an antibody test. It's a serology test. It's a blood test, basically to detect past infection, because we know that antibodies develop within 7 to 14 days after an infection. And this test, after you submit the sample to the lab, you can get the result within half an hour. And it's accurate, but unfortunately, it's not useful to identify current infection. So basically, in terms of how do we manage COVID-19 in the dental practice, I think this is the key message to take home. Defer high-risk patients and treat the rest as if they are all infected with COVID-19. So if we can do that, then we're fairly safe. So let's see how we can defer high-risk patients. So before they come, usually they call for an appointment, and on the phone, we try to confirm several things. Number one is their travel history in the past 21 days. Where have they been? Have they been to high-risk areas such as the US, Brazil, and India, or other high-risk places? Flu symptoms, do they have any symptoms of fever, cough, sneeze, and so on and so forth? Diarrhea is one of them. Do they have any contact with anyone who is confirmed to have COVID-19, or contact with anyone who is currently under quarantine? And if the answer to these questions, or any of these questions, is yes, then we try to defer them. We tell them, well, doesn't, as long as they don't have an urgent problem, then we tell them, well, maybe you should wait, for 21 days before you should come in. We want to wait for all the symptoms to settle. If you've been in contact with people who have been confirmed for COVID-19, we want to make sure that you don't develop any symptoms as a result of that. So we defer these people. And then not only that, when they do come in, if on the phone they tell you no to all these questions, then we send them a health declaration form. They can fill it in before they come in, or they can bring the form in when they arrive for their appointment. And basically, they fill out the same type of information of the 4 questions that we ask, and then we ask them to sign at the bottom. And in Hong Kong, this is legally binding. They cannot lie to us, because if they lie to us and they are convicted, they can be fined, not only fined, but also be imprisoned. So basically the same 4 questions we ask them to confirm on the phone. Everyone who comes to the building has to be checked in terms of their body temperature. And as they enter our office, we check them again. And then once we check them, they submitted the health declaration form, and we ask them to sit down and we observe them. The front desk colleagues will observe them to make sure that they have no flu symptoms. And in the meantime, they all have to wear a mask, and they have to observe social distancing, even in the waiting area. We provide hand sanitizer as they arrive. And for our own staff, everyone has to wear a mask while they are in the office, in the clinic. But we also ask them to declare their own health status. If they have any symptoms of a flu, then we ask them, encourage them to stay home or visit a doctor and don't come to work. So those are the things that we do to defer high-risk patients. Having uniform is important. We try to separate street clothes from work clothes from treatment clothes. So these are 3 different sets of uniform. So you come to work in street clothes, and then we change into scrubs. And then when we start seeing a patient, or before we start seeing a patient, we would have an overcoat on top of the scrubs, and obviously standard precautionary measures of all the PPEs that are required. So at the end of the day, if you want to be extra careful, then you can wash your face, wash your hands before you change into your ordinary street clothes, and then you go home with street clothes, so that you don't try not to bring any germs back to your own home. PPE, surgical scrubs, disposable gowns on top of that, and a mask. Face shield, especially when you're doing aerosol generating procedures. Face shield is an extra layer of protection. Hair cover, gloves, etc. for all the clinical staff. Obviously, the bigger the face shield, the more advantageous it is. But some of these big face shields are not easy to obtain. And if you want to be absolutely sure, this type of PPEs obviously will give you maximum protection, but I'm not sure whether it's practical in the dental office, and it's probably also very expensive to acquire. So I want to spend a little bit of time on masks, because a lot of people ask me about masks. What type of mask should we get? Should we get N95 masks? Well, basically, there are 3 different levels of mask by US standard, ASTM level 1, 2, and 3. And there are 5 different categories where we evaluate these masks. The important ones are, first of all, fluid resistance, and then bacterial filtration efficiency, and then last but not the least, submicron particulate filtration. So fluid resistance is important because, as I said, we do a lot of procedure that generates aerosols. And so level 1 compared to level 2, compared to level 3, level 3 gives us the maximum protection in terms of fluid resistance, and level 1 is the lowest. Bacterial filtration rate, level 1 offers about 95% filtration rate, whereas level 2 and 3, 98%. The size of the particular filtration at 0.1 microns is 95% for level 1, whereas level 2 and 3 offer 98%. So why is 0.1%, 0.1 micron so important? The reason is because that's approximately the size of the coronavirus. So if you look at this figure and consider these important criteria, then you would know level 3 offers the maximum protection, and level 2 followed by level 2 and level 1. And I think in most cases, especially if we're wearing a face shield over our mask, then in most cases, level 2 should be sufficient for general dentistry procedure. But if you're doing surgical procedure, then you may want to consider level 3 to give you the maximum protection. So what about N95 mask? What is the difference? Because people seem to think N95 is the best, it offers the maximum protection. And it's true in a way that N95 was originally designed for industrial use, for construction sites, where you see a lot of dusts, small particles. And the ordinary surgical mask that we put on our face has a lot of little gaps here and there, and the dust can penetrate through these gaps easily. Whereas N95, the way it's designed is that it fits tightly over your face. And so there's less gaps for dust particles to filter in. So it does give you more protection in that sense. But filtration rate is roughly the same. And water resistance or fluid resistance rate is approximately the same. But because it fits tightly over your face, it's also more difficult to breathe through the mask. And I've tried using N95 masks in my dental procedures, and I just couldn't wear it for any extended period of time because you feel like you're suffocating. It's very difficult to breathe. But if you can tolerate it and you don't mind the expenses, then obviously this does give you the maximum protection. But if you ask me whether it's necessary or not, I probably think that it's not. I think, as I said earlier, level 2 or level 3, especially if you wear a face shield over it, should give you sufficient protection. Pre-treatment mouth rinse is important, and you can consider either 1% hydrogen peroxide or 0.2% povidone. Povidone, I've tried it. It's got a very strange and difficult to tolerate taste. And so we don't use povidone in our practice. We use 1% hydrogen peroxide. It still has a slightly weird taste, but it's much more acceptable than povidone. In the past, we used to use chlorhexidine as a rinse, pre-treatment mouth rinse. But chlorhexidine, we know that it's only effective against bacteria and not virus. Rubber dam isolation, whenever it's possible. Obviously, if you're doing a crown preparation or an extraction, you cannot apply the rubber dam. But if you're doing simple restorative procedures, and it's possible to put a rubber dam on, then rubber dam can help you to reduce aerosol in close distance. So within a meter, the percentage of reduction of aerosol is 88%. That's quite significant. and it's even at 2 meters distance, it can reduce aerosol up to 72%. We should definitely consider anti-retraction handpiece to avoid the backflow of any liquid into the dental unit. And I think today, most of the high-speed handpieces that we buy are anti-retraction handpieces, so we don't have to worry too much about it. This is extremely important. In every dental practice, we should practice full hospital standard infection control. Sterilize if possible, disposable wraps for non-sterilizable items, and proper disposal of used items, and proper disinfection as well. So we have designated staff to carry out surface disinfection throughout the office on a frequent basis, especially after a patient leaves. And in terms of disinfection, you can consider 1% hydrogen peroxide or 200 parts per million of hypochlorous acid. This list at the bottom is a list that's recommended by WHO, so you can take a look and pick and choose what you like. There are other devices or protocols that you can consider, and some people ask me, what about HEPA filter? So basically, HEPA filter is is a filter that must remove from the air that passes through the filter at least anywhere from 99.95% to 99.97% of particles whose diameter is equal to 0.3 microns. So that's the definition of a HEPA filter. And if you can get it in your waiting room to filter the air, to refresh the air, the answer is, yeah, it's good, but these are pretty expensive filters. And if you look at the size of the particles that they are required to filter is 0.3 micron. And I mentioned earlier that the coronavirus that we're dealing with, the size is anywhere from 0.1 to 0.2 micron, so it's even smaller than that. So how useful are these HEPA filter? I'm not so sure. And same thing with the other types of air purifier that you can buy on the market. Some people mention UV light. UV light definitely can disinfect. However, it only disinfects a small surface area, and it takes time. You have to shine the UV light on that surface for a duration. I'm not sure, I can't remember the exact duration. But the other thing is UV light is harmful to our eyes. And so if you do choose to use UV light, you have to be extremely careful to make sure your staff are protected or wear protective gear over their eyes. So at one point in time, we split up our team into two teams, Team A and Team B. So this is a business contingency plan. A lot of companies are doing it because they want to minimize the risk of their staff getting infected by the virus. And if one person does get infected, then they can clean up the office, at least allow the other team to go to work. So we've tried that during the height of a community outbreak back in April, I think, in Hong Kong. And it seemed to work pretty well. But for some reason, our team doesn't really like the idea. We have a fantastic team that are very good in terms of working together as a team. At the end of the 2-week period, after we split up the team into A and B, they all come back together and say, "Oh, I miss you. Oh, I miss you." And they just don't like the idea of splitting up the team and don't see each other for an extended period of time. But if you have a huge community outbreak in your area, this may be something that you might want to consider. So, in conclusion, we're exactly 45 minutes into this presentation now. So the first thing I want to highlight is that this is a highly contagious disease, a highly contagious virus. So from the government public health point of view, testing is important because if you don't test, you don't know who has it and who doesn't have it. Contact tracing is important. Once you have identified somebody who's infected, you trace this person's contact and try to find out if these close contacts are also infected. Social distancing is important. As I mentioned, simple sneeze or cough can carry the respiratory droplets as far out as 1.5 to 2 meters away. And so when you stand close to an individual, be sure that you're wearing a mask in order not to breathe in the respiratory droplets that they produce. And if you walk on the streets of Hong Kong today, you see everyone is wearing a mask because it's mandatory. It's a government requirement. And if anyone is not wearing a mask, that person can be fined and can be imprisoned. And as I said, the main reason is because we're undergoing a small community outbreak at the moment. So the government is trying their best to contain the outbreak. And quarantine and isolation are important too. Basically, anyone who arrives in Hong Kong from overseas now, no matter where you come from, has to be home quarantined. And if you come from a high-risk area, you have to be isolated in government facilities. Lockdown, we haven't gotten to that point yet. I know that some countries have, namely the US, in certain cities, in certain states. Shelter in place is important, especially try not to go to crowded places in a group. Personal protective gear, I'm talking about face mask, and sometimes some people even wear a face shield, even walking on the streets. Personal hygiene, as soon as you step into your own home, go to the bathroom, change your clothes and wash your hands. And I think that those are the minimum that you have to do. For dental practice perspective, screening to make sure that we defer all the high-risk patients in our in our office and treat all the others as if they were infected. So PPE, sterilization, proper disinfection, and so on and so forth. Vaccine, I had already mentioned earlier, a lot of countries are racing to produce the first vaccine. But even if there's one or multiple vaccines that are available today, I've asked multiple number of people, are you going to get the vaccine? And the typical answer that I receive is that, well, I think I'll wait a little bit. Because everybody wants to wait and make sure the vaccine is safe, even though it's gone through human testing, in fact, 3 stages of human testing. But I think people still want to make sure that it's safe to receive the vaccine. It has to be inexpensive. Otherwise, some people can afford it and others cannot. And that doesn't do the poor people or the poor country any justice. And it has to be widely available. For dental offices, I'm thinking that it would be nice to develop a quick test. It's accurate and it's inexpensive, so that ideally we can use this quick test to test every patient that comes into our practice to be treated. And then last but not the least, we have to be aware that mutation takes place with these viruses. Some of the reports that I've seen is that some of the latest strain that they discover have more spikes, they are more infectious, and for mortality rate may even be higher. So we don't know. There's a lot of this, since this is a new disease, there's a lot of unknowns, and research producing a lot of reports that are giving more and more information as time goes on. And so we have a lot more to learn. We know some information, but not a lot of information yet. So this is the list of the reliable websites with a lot of good information that you can go to find out more about COVID-19. And that concludes my presentation. And it's exactly 45 minutes. And I'm happy to answer any questions that some people may have.
Thank you, Dr. Williams, for the very brief but compact information, general information about COVID-19 and how it affects our practice and how are we preparing ourselves and our patient and our clinic for to handle patients that are coming in that sometimes can be symptomless. Maybe we can open for question time from all our about 37 of who has to join us tonight. So whilst waiting, Dr. Williams, this Russian vaccine, how can we, I mean, is it reliable or is ahead of other countries about this vaccine for?
Well, I honestly cannot tell you. I'm no expert in the development of vaccine, but what I have heard, the response from an American and a British scientist regarding this latest development from Russia is that it's unreliable. Now, why do they say that? I don't know. I think the Russians are telling us that the vaccine has gone through 3 stages of human trial, and even Putin himself in the news says that it's completely reliable, and he even told us that his or one of his daughters has received the vaccine, and so you hear both sides of the story. And which is true, which is not true, whether it's true or not, I honestly cannot tell you. I think only time can tell.
Okay, thank you, Dr. Williams. There's a question from our audience in the chat. He said about comment on the use of half-face or full-face reusable respirator for dental practice.
Oh, half-face or full-face reusable respirator for dental practice. So I explained to you about the difference between the N95 face mask as opposed to the surgical face mask that we use, and surgical face mask has level 1, level 2, and level 3. So my recommendation would be to consider for ordinary general dentistry procedure, level 2 plus the face shield. If you're doing surgical procedure, level 3 with a face shield. But if you can afford the extra cost and you don't mind that breathing is not as easy with the N95, then you wear an N95 with a face shield. I'm not really familiar with half-face or full-face reusable respirator. I don't think I've come across one, so I can't really comment on it.
Right, thank you. There's Prof. Arshad Malik. He has put up his hand. Prof. Arshad, do you want to ask the question personally?
Yeah, Arshad.
Hello, William.
Hello, Arshad.
How are you?
I'm good.
Actually, I have a question. With reference to vaccine, they have gone for the 3 immuno schools, and they have approximately 6-month trial. I don't know that a 6-month trial is possible of the vaccine. It is what these Russian people are saying. But they say that we have gone for all the multiple stages, and we have got the vaccine. And here from 3 or 4 centers in Pakistan, they have booked the vaccines from Russia. And government, I'm to some extent is one of the advisors of one or two universities, and they asked me that we want to purchase this vaccine, whether you recommend it or not. And my answer was the same what the William has said, that yet because it is no doubt the presidents are not the authority on any medical subject. Like what you say that the American president is saying that the chloroquine, you start chloroquine. He is not the authority, or neither the Russian president. So it is a thing to be improved with the passage of time, but no doubt they are saying with very much confidence that this vaccine is safe. One thing is that. Secondly, the person who said the half mask or full mask or fully, these are the 4-5 types of mask. Now this is just drama that you are going to have the half face mask. Actually, best thing is that if you are allergic or you are in suffocation with the N95, do the double masking of the surgical gloves. That is more promising if you are you have the problem with that. And my personal comments to William photo team number 1 and team number 2 is that whether this team was standing in the clinic or outside the clinic, no mask, no social distancing. That is my comments. So,
well, those pictures were taken for fun. So, no, I thank you for your comment. But wearing double mask is certainly an option, an alternative. But like wearing an N95 mask, it's not easy to breathe comfortably through double mask. I've tried it, but if you can, then obviously it will give you extra protection, no doubt about it. So I saw TC Pua's question about the difference between dental aerosol and medical aerosol. TC, thank you for the question, but I really don't have an answer for you. And I haven't read any report regarding this difference. And then there's another question related to the use of high-speed evacuation, high-volume evacuation. I think, you know, everything that we do today, we use high-volume evacuation. And I think it's absolutely necessary because it will help to pick up a lot of the aerosol that we generate through the procedures that we do. Yeah, there's no question that it's necessary. I think that's all the questions that I saw through chat. Yeah.
Yeah, just one last question from me. I think in the initial part of your presentation, you did mention about origin from Pangolians, but what we heard from Malaysia is about BAT, other than Pangolians. So which one is it actually?
I don't know. I don't have an answer. I don't think anybody has an answer. The reason they speculate that it's Pangolian is because they analyze their genetic sequencing. It's 99% similar to you know, SARS coronavirus 2. So this particular virus. So that's the reason why they speculate. And I only said it's a speculation, pure speculation. It's not confirmed.
All right. Okay. Thank you very much, Dr. William. We are almost right on the spot, 1 hour. Thank you very much for sharing with our fellows and our dental fraternity around the world, I would say. And we hope that it's certainly useful with a brief, concise of all very specific to our nature of our practice. And again, on behalf of the ICD Section 16, we would like to thank you for for sharing your experience. And I would like to invite all of you again for next week. We have another speaker from China, actually, Dr. Yu Liu. He is going to talk about how much we can do for class 2 malocclusion. And finally, for the month of August, we have a speaker from Pakistan. All right. So again, thank you very much, Dr. William. And
Thank you. It's my pleasure. Thank you for inviting me.
For joining us, and see you all. We meet again next Wednesday, same time, with this topic from orthodontics, and this time is not related to COVID-19. Thank you very much, and have a good night, and see you again next week.
Goodbye, everyone, and stay healthy.
Okay, thank you.